in the Obama administration. Thank you, Dr. Frieden, for taking the time to join me in this conversation this afternoon.
It's wonderful to speak with you, Reverend Brown, and I think the concept of a just conversation is just what we need.
Indeed. So there are many issues that I want to get into in our short time together. So let me jump right in and let me begin. Before we talk about the work that you do with Resolve to Save Lives, let's begin with where we are 1 year later when it comes to COVID. This time last year, we were in the middle of a lockdown with different parts of the country resistant to mask wearing, social distancing, and the like, even as we were all anxiously awaiting for vaccines. Now here we are in the middle of opening up with vaccines available, yet with people resistant to taking the vaccine, even with the Delta variant spreading. Dr. Fauci has warned of two different Americas as we look at vaccine rates across the country. Can you speak to this, and what does it mean for the country if we cannot move more people toward vaccinations? What's the risk?
Well, I think, as you say, Reverend, there has been enormous progress. A year ago, we didn't have a vaccine. A year ago, we didn't know how long this would go on. And we are fortunate in that research that has been done for decades has come to fruition with very, very good vaccines now, very effective, very safe. And so it's, for a public health doctor, it's painful to see the number of people who don't have the vaccine, either because there's a trust gap or because there's an access gap and they can't access it readily. Now, globally, we have a terrible access gap. Less than 1% of all vaccines have been given in low-income countries. But even in the US, although hesitancy is a major issue, there are pragmatic barriers. And whether it's hours of work or time off from work to get vaccinated, or time off if someone has a fever afterwards, or the kind of facilities that vaccines are being provided in. But we are really in this increasingly bifurcated world of the vaccine haves and the vaccine have-nots or vaccine will-nots. And in either case, you really do have a lot of susceptibility. The Delta variant is quite concerning in that it's much more transmissible than the base types, the wild type, as we say, the original types of the virus. We don't yet know for sure if it causes more severe disease. That's something that's still being studied. And there's just good data out now that the vaccines work quite well against it. So, but we also have to understand that vaccines aren't 100%. If you've got an immunocompromising condition, you maybe want to be more careful. But generally, the Delta variant is much more transmissible, but it can't get around the very effective vaccines that we've got.
Well, in fact, as you say that, I just texted some friends and family members who were concerned about the efficacy of the vaccines in relationship to the Delta variant. And so I saw one of your tweets this morning and texted that out, that they are indeed effective. I like the way in which you speak of the, not simply the will-nots, but the sort of have and the have-nots when it comes to the vaccine and the access, and thinking about people who put their jobs in many respects at risk, and they're worried, right, about the impact and the symptoms that will follow taking the vaccine and the time off work. I also like that you talk about this in relationship to our global community, because COVID has shown us that we are in a interrelated global community. What is our responsibility as a nation to developing nations, which are typically people of color, and specifically in relationship to making sure that they receive the vaccine and have access to the vaccine?
What we've seen, Reverend, is that around the world, vaccine nationalism is ethically unacceptable, but it's politically inevitable.
Yes.
And therefore, I think what we need is not, but we do need to reallocate existing doses, absolutely. But even more than that, we need to ramp up supply. We need a bigger pie rather than slicing the pie just differently, though we do need to reallocate existing. And here we have to say, this is a matter of life and death, not of just a few people, but of millions of people.
That's right.
And we think that the government should basically strongly encourage companies such as Moderna to share their technology with other entities that can ramp up production much more rapidly. We have a gap. We have a short-term gap and a medium-term gap. We have a short-term gap in the coming months of hundreds of millions of doses short globally. And in the medium term, we're short billions of doses. So we can't just rely on industry to say it's going to be all right. We really have to do a better job ramping up production, because if we don't, we do that at our peril, because more variants like the Delta variant can emerge, can spread, and the Delta variant may not be the worst variant that this virus has dealt us. The next one, or the one after that, could be much more lethal. It could overcome some of the immunity that we have to vaccines. So we have to keep a watchful eye.
Well, that's not good news, but what we do know is we can prevent that. We can be proactive and not reactive. And I really like this distinction you've made between the ethical, the political, and sometimes the economic, right? And it's the same kind of distinction we've heard in our context about essential workers. And those essential workers aren't oftentimes treated like essential human beings. And so somehow we have to allow the ethical discourse to overcome the political and economic discourse, because human lives are at stake and we are all interconnected. Which leads me to this, one of the starting realities of this health emergency, of course, has been the recognition of the way in which racism has impacted the lives disproportionately of people of color, leading the CDC to declare racism a health emergency, something that many of us have talked about for a long time. And other organizations have stated that racism is a health emergency. Nothing made this clearer than, of course, the COVID disparities, and a report that came out within the last week or so, showing that Black Americans and Hispanic Americans have lost about over 3 years in terms of the mortality rate, and disproportionately so when it comes to white Americans, who their mortality decrease has been about 1.36 years, according to the report. So with that said, what must the medical community's response be to this in order to close this kind of gap? What difference does it make in declaring that racism is a health emergency beyond the declaration itself?
I think there are a few things that are really important to keep in mind here, and more importantly, to act on here. One is there is a very important role of health and public health in bearing witness, in being clear about where there are disparities, where there are health gaps, being clear about that. But more importantly, really, is taking action to reduce those gaps, identifying both general and specific actions that can make a big difference. The general ones may be something as broad as the childhood tax credit, which is an anti-poverty program that's going to help Black, white, American Indian, Hispanic, Asian families, all families that are struggling to raise their kids as well as they can. That will be not just an anti-poverty, but an anti-ill health initiative that will be very effective at addressing opportunity and addressing health opportunity. There are also very specific programs that can improve health in the Black community and in other communities that bear disproportionate burdens, whether that's addressing teen and unintended pregnancy, hypertension, or other conditions. So I like to think of the bearing witness function, the function of general action that will make a huge difference in the structure of society, whether it's economics or political power or community organizing or community strengths, community resources, or the very specific health programs that should be held accountable for having outcomes that really make a difference in people's lives. But just a word on the concept of an emergency. The fact is that every day in this country, many Black people die young or have disabling strokes or heart attacks or infections at a rate much higher than other people in society. And it doesn't get the kind of attention that a dramatic event gets, whether that's an epidemic or an act of violence or something else, which is awful. But the numbers are just shocking and unacceptable. And I think we need to recognize that it's unacceptable, and we have to take action appropriately.
No, you are exactly right. You know, many people have spoken about the way COVID-19 pandemic laid bare certain disparities and, of course, the gaps in terms of health related gaps and other things, when these were disparities that people who were suffering knew all along, and the communities of color knew all along. So we knew that there was a health emergency in terms of the daily lives of people of color. What you have recognized in your response is the interrelationship between conditions of poverty that create these comorbidities, as we've come to understand them, comorbidities that are the lack of housing opportunities, educational opportunities, employment opportunities, and of course, health options. And so the discourse in this country, as it comes to reckon with these racial injustices and inequities, has been one of reparations, and talking about how we can begin to close the gap and repair the breach created by a legacy of slavery that is white supremacy, white racism. What about in the scientific and medical community? What would reparations in this regard look like, especially when we know that this is a part of that same legacy of racism? And we can talk even more specifically about the differential healthcare that people of color receive, regardless sometimes of the wealth gap. Can we begin to talk about sort of a program of medical reparations? Will we ever be able to close this gap?
I think the fundamental question is, how do we close the gap in healthy life expectancy? And that has to start before birth. That has to start with healthy pregnancy, has to start with everything from the stress that people feel in their communities, to the violence they experience, to the economic opportunities, educational opportunities that they have. If we were doing this rationally, we would say children with greater needs should, of course, have greater resources for their educational investments. But that's exactly the opposite of what we do. People with the children with lesser needs get much greater educational inputs and other inputs.
That's right.
Sticking with healthcare, I think we really do have to think a lot about healthy pregnancy, having women have control over whether and when they become pregnant. And then there are some very exciting programs such as the Nurse-Family Partnership, which has been shown to greatly improve outcomes of first-time mothers and their infants. It's an intensive program, requires a lot of important and intensive work, but it can really make a difference. Making sure that there's a real medical home for everyone in the family, so that there is a clinician who knows their situation, is trusted by them, deserves their trust, earns their trust, strengthens their trust, and then can make sure that they get the opportunities for the care they need to stay healthy. That kind of a relationship with the healthcare system is something that's actually lacking, not just in the Black community, but in most communities in the US, because the way we structure our healthcare in this country does not emphasize primary care. It doesn't emphasize keeping people healthy. And I think we all suffer because of that.
Yeah, and we know, I mean, even as you speak of these things, that people of color are so disproportionately trapped in conditions that promote death, not life, and that's not their choice. When we talk about women have choices about becoming pregnant, well, you have to create a situation in which they indeed do have choices. And so as we talk about a breach, there's a wealth gap and a choice gap. And so we have to close those gaps. Let me talk, we've run out of time, talk about an issue you raised that is very significant in terms of particularly the health results in the African-American community. This is hypertension. And I know Resolve to Save Lives is very focused on this matter of hypertension. Can you speak to that?
Around the world, hypertension or high blood pressure kills more people than any other cause, more than all infectious diseases combined, more than AIDS, TB, malaria, all other infectious diseases. Over 10 million people a year around the world killed by hypertension. Within the US, hypertension is the single most important and undertreated medical problem. And it's much worse in the Black community than the white community. In the white community, among adults over the age of 18, 1 out of 7 have hypertension that isn't well controlled. That's a horrifically high number. In the Black community, it's 1 out of 4. So that's just shockingly bad. And we know the rate of hypertension is higher in Black people than white people. It's about 40% in Black Americans versus the low 30s in white Americans. And the level of control is lower. And because of that, uncontrolled high blood pressure is the single leading driver of differences in life expectancy between Black people and white people in this country. Now, there are things that we would want to do longer term to reduce the risk of hypertension. That includes low sodium diets, eating more potassium, getting regular physical activity. Physical activity is the closest thing we have to a wonder drug. Makes everything you'd like to have more of better, everything you'd like to have less of, less of. But realistically, most people are going to need medications for life. That means taking 1, 2, sometimes 3 pills a day, every day. There are very effective, very safe, very inexpensive medications, but we need to close that medication gap because healthcare systems and countries around the world that do a good job prevent heart attacks, strokes, and early death, kidney failure, and other problems, including dementia or problems thinking, which high blood pressure can cause. So I would really love to see a focused effort to improve control of blood pressure in all the country, especially among Black Americans.
Yeah, and if we focus on hypertension, that is high blood pressure, it allows us, it sort of moves out from there, right? Because not only is that a hub for so many other health concerns and health issues, but if we begin to focus on the reasons for hypertension, we can begin to see the intersecting social, political, economic realities that have created even the disparity in relationship to those who suffer from hypertension. So I really appreciate the way in which Resolve to Save Lives has made this a focus issue, because while a focus issue, it's fundamental and brings together all the intersecting realities that have created these kind of health gaps. Time for just 2 quick questions, more quick questions from you. And one is this: as we talk about these gaps, and we talk about the vaccination gap, all of that, and we have seen the distrust, as you have spoken about, in the scientific and medical community, et cetera. But this is important. You're talking about life-saving information, life-saving vaccines, medicines. How, Dr. Frieden, do you begin to lead across the differences, particularly when we are talking about life-saving realities?
Well, I think we do have a trust gap, many trust gaps in this society and many fissures in it. And we have to start by listening to the problems people face in their everyday lives, listening to the perceptions they have about the recommendations we're making. Just today, Reverend Douglas, we released a report about vaccine hesitancy and what difference would it make if people learned about long COVID or long haul COVID, that there are people suffering for weeks or months, and we don't know, we hope not, but maybe years, brain fog, shortness of breath, inability to smell or taste. And that might be one thing that would increase vaccination interest and willingness. But I think all good communication and trust building has to start with listening, hearing what the perceptions and problems are, addressing to the best of our ability those things that we can address. If there are things we can't address, being honest that, you know, we will do what we can, but we may not be able to address that, but we'll work with you or advocate with you for it, and then provide fact-based, clear information.
No, I like that it begins in listening and trying to understand where, in fact, people, their perspective and where they're coming from. I always like to end with this question about a just society. So from your vantage point, Dr. Frieden, as a medical professional, a scientist, and head of Resolve to Save Lives, if you were to close your eyes, what does a just society look like?
Well, there are many aspects to that, but I'll just mention one. And it's that in a just society, every single child would reach adulthood healthy. And that means at a healthy weight, with healthy habits of physical activity, not addicted to drugs, alcohol, or nicotine, or digital devices, would reach adulthood able to reach their full potential for their own sake, their family's sake, and their community's sake. Able to reach adulthood without having experienced any of the childhood traumas that we know can undermine health later on, whether that's domestic violence or other traumatic situations in the home. Because if we start with kids who reach adulthood healthy, we have the basis of a just society.
I'm reminded of the biblical scripture that says a little child shall lead. And so indeed, our children will lead us to a just society if indeed, as you say, we ensure that they are healthy. Thank you, Dr. Frieden, for not simply this conversation, but the work you are doing now and the work that you have been engaged in for a very long time to indeed help us to save lives. I thank you.
Thank you very much, Reverend Douglas. It's an honor speaking with you, and thank you for the work that you do.
Oh, my honor. Thank you. And thank you all for joining us.